So I come in now and I'm Part D or dually eligible. And I say, wow, I'm in the donut hole. You say, do I go to the financial counselor and say same thing? Hey, I need a patient assistance program.
Typically, our staff is already looking ahead.
Okay.
We work ahead because, again, we do not want our patients without drug.
Right, and you don't want to have the conversation go down one path and then have to back up from that conversation. So you know ahead of time, you've prepared for this, you know that I'm a Part D recipient, and the conversation's a little bit different. Why?
Because with Part D, there's a lot more restrictions with government programs.
So there's a lot more regulatory requirements, less...
There's limited resources they're eligible for.
Okay, so there's limited resources and regulatory considerations, can't do this, can't do that.
Correct.
So basically then it sounds to me like what you have as far as patient assistance is, here's what can't be done with the public payer programs, and then here's some flexibility that you have out here in the non-public payer program space. Is that accurate?
Yes.
Okay, so how do I take the handcuffs off in the public payer spot if I'm that person, and how are you helping me?
And actually, Medicare itself, so they offer what's called LIS, or the low income subsidy.
Okay, so if I'm dually eligible or I'm eligible for the low income subsidy, that dramatically reduces my copay anyways.
Absolutely. So it helps with copay. It helps if you fall within that donut hole and you're obviously paying a lot more. So it helps minimize all of that burden.
So
for
in the
patients.
thinking ahead part for both of your practices, at some point along the line, somebody's flagged, hey, we need to see if this person's LIS eligible, because why are we even having the conversation if really it's about making sure that they are categorically eligible, that they actually get that LIS? Okay, so I'm not LIS. Now what? Not many options?
Unfortunately, in many cases...
Take out a personal loan?
And unfortunately, this is
Bye-bye
where
Phoenix second home?
you really need to, at this point, really talking to the drug manufacturers and potentially applying for free drug. Because you also have to think about it, these drug manufacturers, they're making tons of money off the medication, but outside of that, there's mutual benefit, because if for some reason, if the insurance is saying no to cover a medication, it could potentially be a, not yet FDA approved, or it could be an off-label indication. So, but if the actual drug companies have an X number of patients that they're able to provide free drug for, and they're seeing benefit in this specific indication, they can go and run clinical trials and potentially try to get that drug approved or expand that approval in that specific indication. So oftentimes, the government-funded plans, you're limited on what kind of foundation money and copay assistance, but also though sometimes institutions themselves are able to provide financial assistance for patients. There are several organizations that, even if the copay for patients is too high, and unfortunately the patient has to pay it, there is other types of foundation money that's there that can help offset the cost of food, the cost of living, the cost of travel expenses. So these are all.
So you're saying the U.S. healthcare system has gone from cost shifting within healthcare delivery to cost shifting beyond healthcare delivery?
Sometimes we have to, when our hands are tied.
You're patient advocates, you've got the practices. So from your perspective, Mike, at the association, if you could wave a magic wand and say, here's some policy considerations that would be really good for the patient, the whole system, what would they be?
So if there weren't the restriction that Medicare patients cannot be eligible for the manufacturer's copay cards, that would solve all of this. About 2 years ago, there was a lot of heightened scrutiny with the foundations and the whole model behind foundation support. And because of that, in the last couple of years, there's been a tremendous amount of reduced funding from the manufacturers to the foundations to help out our patients receive their oral therapies. And because of that, what manufacturers have seen, they've seen a precipitous, huge increase in the amount of free drug that we've talked about earlier, that patients are now eligible for, and that's the route in which we have to go as providers to get that patient the medication that they need. It's through the manufacturer's free drug.
Sounds to me like the free drug program is subsidizing the plan, though.
Well, this is a path that we have had to take due to the fact that the foundation supports have, I wouldn't say, they've dwindled or waned quite a bit.
So it's not optimal, it's just what's available.
It's what's available.
But you have a magic policy wand, you have an elder wand.
Yes.
So
what would I do?
What would you do?
Yeah, I would allow Medicare patients to be able to use the manufacturer's copay cards. I mean, that would be
So
ideal.
those are a good, elegant solution from your perspective.
Yeah, of course.
Okay. Anything else? You have a magic elder wand for the next 30 seconds.
No, I think that would cure just about all the copay concerns that I could think of for the oral oncolytics.
Part D.
And just to speak to Mike's, the amount of free drug that's been utilized, our institution at the University of Minnesota in 2017, they were actually able to procure over $6 million of free drug for patients. So that
From
is how-
manufacturers?
From manufacturers. Alone.
Because you said pretty please, or because
It's being adamant. It's advocating for that patient, wanting to do the right thing for that patient, because we know that there's a need. This is the right treatment, but we are limited by the payers. So and there is a gap there. And yes, if copay cards can be used, the problem is solved.